It's February 7th, 2025. This is the Room Now podcast. Hi, I'm Jack Cush, executive editor of RoomNow.com. February 7th, that means tomorrow, February 8th, is Patrick's birthday. Happy birthday, Patrick. You know who you are. This week, a lot of interesting things happening in the wild world of rheumatology. One of the shocking ones was a Medscape survey. You know, they do those surveys at Medscape about the lives of physicians, our income, and you know, who's best, who's least, whatever, based on their surveys of thousands of doctors. And they came up with their Who's the Happiest Specialist survey. They do this once a year. And, you know, for years we've talked about rheumatologists being amongst the happiest of the subspecialties. It's sort of like in Norway, they're supposedly the happiest people. And I heard one joke was that's because the expectations are so low in Norway because it's so cold. I don't know if that's true. I've never been to Norway. Please invite me. I would love to find out why people in Norway are happy. But anyway, rheumatologists are really happy, but not this time around. We dropped like a lead bullet. I mean, my goodness. So at one point, you know, we were number one and number two, and now we're fifth from the bottom. At the top of the mix, you know, as far as, you know, are you very happy or whatnot? Allergy, 94% said yes. Pathology, 88%. Dermatology, 87%. You know, like the top five are also like, you know, the top five income in subspecialties. In the bottom, you know, fifth from the bottom, 67% rheumatology. We're just 1 point better than internal medicine at 66%. How is that? Well, I looked at the survey on Medscape. You can look at it too. The only fault I have with it is that only 1% of the people they surveyed were rheumatologists. So do they have an adequate sample is one thing. Has life changed in rheumatology? Rheumatology is older. There's a lot of burnout in rheumatology, a lot of, you know, the deluge of white-haired retiring rheumatologists, and maybe you're adding to the negativity. I don't know that we really are that unhappy or relatively unhappy compared to other people. I'm happier than all the allergists, pathologists, and dermatologists I know. But nonetheless, your ranking drops. So wear a smile, do good things. The FDA has made some decisions this week about drugs. Maybe the major one was at the end of last week, they approved a new drug for pain relief. It's to treat moderate to severe pain in adults. The drug is called Journavx, Journavx. The generic is suzetrigine, Suzetrigine. You know, so pronouncing these names kind of hard, isn't it? I mean, I got to look at it. I got to study it. I got to recite it in the mirror like I'm studying my lines. I got to make it sound like it's easy when it's not easy. And then, you know, the letters don't go together. You know, of course, all the words are taken. If you want to name a website these days, you can't. You know, you can't come up with something like Starbucks or Yahoo because everything's taken. You got to put five words together. Well, here they put words and letters together that don't make any sense. You know, Jorvanax, it's a pain medicine, first in class, non-opioid analgesic. It reduces pain by targeting sodium channels in the nervous system somehow. Not sure how that works. You got to welcome another pain medicine. It's a non-opioid solution. That's great. Have no experience with this. I have great hope for it. But I'm really perplexed by the names. Suzetrigine, the generic, has got like 10 letters, 5 vowels. The trade name, Journavx, has got 8 letters and only 3 vowels. I think there's something there, don't you think? The trade name, meant to get attention, it's got more consonants, less of those vowels. Generic, nobody cares about. There's always way too many vowels in the generics, and making them maybe a little easier, although they are longer. in words. Naming drugs is a real pain in the neck. We'll see with the next report. It's another drug name that's gone bad. So, actually, it's some companies, they have competitions when they're coming up. They got a new drug. It's called KP90707. And what are we going to call it? And it comes up with a generic, and then they have company competitions where everybody from the janitor to the, CEO can put in a name. And sometimes that works better than hiring, multi-million-dollar ad agencies. Because the ad agency is going to get you a name like Vioxx, V's and X's and T's and, that gets attention, right? Those hard consonants. There ain't no great drugs with an H in it at the front as the first letter. Halcyon. Actually, it sounds like a name that would put you to sleep. But lots of vowels, right? Hard vowels. And limit lots of consonants, hard consonants. Limit the vowels. The next one, there was a new biosimilar approved, a tocilizumab biosimilar. It's the third biosimilar approved by the FDA from Celltrion. They've got 7 biosimilars in the market. They're taking it over, are they not? This one is called, was in development, it was called CTP47. Its generic name is tocilizumab EIEIO. In the FDA, they add on 4 letters at the end, and this is ANOH for tocilizumab. But the trade name is Avtozma, AVTOZMA. What's that? 7 letters, only 2 vowels. And it's got a V and a Z and and a T, and starts with an Av. It gets attention. Tocilizumab is like 11 letters, and it's got 4 vowels, and it 2 more if you add on the extension. Again, this naming thing in medicine is getting to the point of being crazy. But anyway, this is the third tocilizumab biosimilar. The first one was approved in 23 from Biogen called Tofidence. And then earlier this year, Fresenius Kabi has one called Tyenne, Tyenne. This one, Avtozma, is IV and sub-Q. It's approved for all the things that tocilizumab is approved for. That includes RA, polyarticular JIA, giant cell arteritis, Still's disease, COVID-19, etc. Okay? So that's good news if you're in the biosimilar biz. Another report this week that affirms that which we all know, obesity and overweight increase the risk of chronic inflammatory diseases. This is a Trinetics a survey or a study of electronic health record data on over 3 million people, showing that being overweight or obesity increases, for any of the chronic inflammatory diseases, obesity and overweight was 29%, whereas in controls, it was only 17.6%. So this is what we know, that, obesity is a risk factor for the development of disease. It may also worsen disease. It may also make drug responsiveness less. But why does it increase the risk of getting chronic inflammatory diseases? It's been seen in RA, in lupus, in JIA, in SPA, in PSA. Why? It's not simply wear and tear and more pounding on the joints with higher weight. That leads to degenerative disease. We're talking about developing inflammatory disease de novo. So it's either that there's something stimulatory about bad diets. It's either that bad diets lead to bad microbiomes. It's either that bad diets directly lead to or indirectly lead to immune dysfunction. If that were the case, maybe obesity would be also linked to some cancers. And I think that actually has been seen many times. So I think it's really simple. If you look at the clinical disease model that Kevin Dean and others have come up with. Mike Holler's Kevin Dean. It says that you're genetically susceptible. There's an environmental trigger that with genetic susceptibility and environmental trigger, you get autoimmunity, and one more, one more tick, one more factor will get you into disease progression. What's the environmental triggers? I think bad diet is pollution. It's the same as environmental pollution. This week at Room Now Live, tomorrow, actually it's going to be on Sunday, Karen Kostenbatter is giving a TED Talk, like we call them Step Talks at Room Now Live, on environmental rheumatology. And this should be big. I've talked about this recently. I think this is a big thing. How we get disease is largely from the hazards that are in our environment. Bad diet is pollution. You can quote me on that. A study from the University of Minnesota looked at the risk of I'm sorry, not the risk, but actually mortality figures in young adults ages 25 through 44. So that's young and middle-aged adults, and looking at mortality. And they show that from 2011 to 2023, the risk of mortality in this segment of the population has gone up disproportionately so. And in this JAMA article, this excess mortality in younger adults is a societal thing. The biggest contributor to that number was 32% with drug poisoning. That's not surprising. But also all the other things that you would expect, and that includes transportation deaths, alcohol-related deaths, homicides. Suicide was on the list, but not in the top 5. That's obviously a bigger issue with younger adults under age 25. So I think this is disquieting. We don't see anything about rheumatology diseases or autoimmune diseases in this population as a cause of death. That wasn't covered in this paper. But I think that this is an important statistic that we need to keep in mind. A study on how you get from psoriasis to psoriatic arthritis, another lecture at Room Now Live tomorrow from Alexis Ogdi, where she's looked at this in many different ways, showing that some studies show it, some studies don't. This particular study is another one of those, I believe this is not the Trinetics. This is actually a study about factors that are different between those who transitioned from psoriasis to psoriatic arthritis, and the median time frame for that was 9 years, right? And that goes along with what's been published before. So they looked at people who were transitioning before 9 years, with less than 9 years of symptoms before they got psoriatic arthritis, or after, and they found that the late transition group had lower disease activity, less DMARD use, but no differences in radiographic progression. So there are differences in those that will maybe get there sooner versus those that will get there later. I'm not sure how this is going to change treatment. What Alexis Ogdi is going to address at her lecture is whether aggressive treatment of psoriasis, for instance, with either biologics or targeted synthetics, whether aggressive, effective treatment of psoriasis may lessen the risk of psoriatic arthritis. And again, I think that the pre-message here is that there are some studies that show it, and they're often methodologically flawed, and there are a few studies that don't show it. So maybe it's hard to say, and there could be channeling bias. But anyway, that's my next report, a Trinetics report, which again looks at millions and millions of people from the electronic health records. And it looks at retrospective data. And in this study, they just compared patients with psoriasis who were either treated with an IL-23 inhibitor or an IL-17 inhibitor. And in this retrospective real-world EHR data, comparing about 2,300 patients on either drug or either class of drugs, that the IL-23 inhibitor patients had a slower risk of developing PSA with about a 40% lower risk, a hazard ratio of 0.60, with confidence intervals of 0.44 to 0.82, and that being very significant. This was a little higher, or significantly higher, if we're looking only at 41 to 65-year-olds with psoriasis, where the hazard ratio went down to 0.42, which means that that's a 58% reduced risk. Is this real? It's hard to know. It's manufactured data. The Trinetics, there's problems of propensity matching. It's not easy to do. It's often not well done. So these are very fast and loose comparisons. But short of head-to-head studies, how are we going to know? Anyway, I'm going to show up and see if Dr. Agdi addresses this in her lecture on can you prevent psoriatic arthritis in psoriasis patients. So that this is about a unique study design issue using the Trinetics database on EHR data. Another interesting data analysis thing that we're seeing are these target trial emulation studies where you take a large cohort of people and you emulate a particular trial and the characteristics of a trial and select those patients out. So this is a target trial emulation study from USTAR. This is a study, USTAR is a data set that studies systemic sclerosis. And in this one, they looked at 208 patients with early diffuse systemic sclerosis and wanted to ask the question, does adding glucocorticoids to immunosuppressive therapy change skin scores as measured by the Modified Rodnan Skin Score, MRSS, named for its inventor Dr. Gerald Rodnan at University of Pittsburgh. And they showed that adding PO steroids up to 20 milligrams per day to existing immunosuppressives did not make any difference in the Modified Rodnan Skin Scores. They were similar as far as how they change when followed over time, over 24 months. Both groups dropped minus 2.7 versus minus 3.1. No significant difference, not any different if they had a high Modified Rodnan Skin Score or a low Modified Rodnan Skin Score. They used a cutoff of 22. I think that's kind of high, actually. But nonetheless, I think that it answers the question of if you see early progressing systemic sclerosis of the diffuse type, will you blast them with steroids? I have done that because that's been suggested, but you got to worry about, renal crisis in those patients and whatnot. This data suggests that maybe it doesn't do anything. But then again, this data, target trial emulation study, the mean dose of steroids that they're looking at here is about 5 milligrams. It wasn't 20. It wasn't a Medrol dose pack. It wasn't 60-40, 20-10 over 10 days, something like that. So I still think this is an open issue, but I'd like to know what Dinesh Khanna thinks. I'm going to ask him when I see him. A Danish study looked at the influence of systemic glucocorticoid exposure to women who were pregnant. So this is a study of 1 million infant births and compared those who were exposed to unexposed during the prenatal period. And they showed that glucocorticoid exposure was associated with a higher risk of mental disorders. Autism increased 50%, a relative risk of 1.5. These are significant. Intellectual disabilities, 1.3, 30% increased risk. ADHD, also 1.3. Mood anxiety disorders, 1.3. Of the 1 million infant births, about 290,000 were born to mothers with autoimmune or inflammatory diseases. The exact same numbers were seen. That steroid use may have a downstream effect on the unborn child. Mechanistically, how does that work? I don't know. Making a baby, it's a black box, and that's just that's a male talking, so a single, and even worse, a single male talking. You figure it out. Let me know. UK has also done cohort analyses of their lupus populations who are hospitalized with an alarming figure. So in 2023 and 2024, their figures by NICE and the National Health Service shows that hospitalizations for SLE were 8 times higher in their black population. That's 62.6 per 100,000 hospitalizations compared to whites, which was only 7.8 per 100,000. What? It was a little higher in Asians, 26. But even still, blacks are more than double the Asians and about 9 times more than the whites. They found that lupus hospitalizations have increased 50% in the last 4 years, from 6,300 to over 8,000 in 23-24. Why is this inequality being seen in this population? Is it because, and they don't really have the answers, these are just hospitalization numbers. Is there an inequality of care? Is it a lack of access? Is it a delay in diagnosis? Clearly, in the UK and NICE are going to need to address this with public policy. That's how we do this kind of research, to see if we can do something about public policy. We've talked about fibromyalgia in lupus recently. This is a cross-sectional study of 50 lupus patients. It's a small study. 24% had fibromyalgia. 18% had widespread pain. Fibromyalgia. Why don't we just call it fibromyalgia instead of turning it into an adverb or whatever you would call fibromyalgia? The point being that, 2 out of 6, at least of my patients, maybe 1 out of 6 lupus patients are going to have fibromyalgia, complicating your management, complicating your assessments. I like this AI report this week. Another interesting thing at Room Now. Jeff Kerr is going to be talking about AI and rheumatoid arthritis. This is a machine learning algorithm that was developed in a large primary healthcare data set to see if they could identify early undiagnosed RA. And they went through, I think they had 29 variables. They actually narrowed it down to 11 features that in a test set and then in a validation set showed great performance in identifying early RA. The 11 features used by AI through machine learning that diagnosed it was rheumatoid factor, CRP, SED rate, uric acid, hemoglobin, platelets, morning stiffness, age, tender joint count, swollen joint count, and deformity, if they're mentioned anywhere in these electronic records. What they found was a 96% specificity, 96% sensitivity, 96% area under the curve. Yeah, AI is going to make us smarter. It's not going to make decisions for you, but it's going to be a tool that you will use in your practice or in your research. I'm fully behind it. I like this report this week. I think it was from Lancet Rheumatology. Shows that using a TNF inhibitor, if you've got cancer, does not change the outcome. I've been yelling and screaming about this all the time. Many of you are become adversely handicapped when the patient has cancer, develops cancer, has cancer, and you don't know if you can use your drugs. And the ACR rules, guidelines say if it's a solid cancer, use whatever you're going to use. It doesn't really matter. They got a bunch of things wrong when it's a hematologic or lymphoproliferative disorder, but we're not going to talk about that. In this study, 3 cohorts of patients with either colorectal cancer, 500 patients, lung cancer, 864, prostate cancer, 605. Either 12 to 20% of these cancer patients were on a TNF inhibitor. And it turns out their overall survival was not different, meaning these were not worse. In fact, they're less. But the confidence intervals overlap 1, so they're not truly inferior. But again, the hazard ratio on colorectal cancer was 0.72, confidence intervals of 0.43 to 1.21. Lung was 0.70, prostate 0.80. So they don't go up. If anything, they might go down or trend down a little bit. Oh, by the way, in contrast, steroid use was associated with a significantly worse survival. Now, that could be just it's a surrogate marker for people with worse disease. People with worse disease are going to die. And I'm not saying what's the worst disease. It could have been their arthritis is worse, their cancer is worse. No one knew it was worse, but nonetheless, not surprising that they would have worse survival. But again, this is sobering and good information for you who want to know what to do when your cancer patients are seen by you. Treat them as if they didn't have cancer is my advice. I like this last report that was in J Room with a nice commentary editorial by Hani Gabalwe and others. Is rheumatoid arthritis becoming milder? And this is a Canadian Ontario province study where they were enrolling patients in the early undifferentiated polyarthritis study. They got lots and lots of patients, tons of patients, and they divided them up. I think it was about, I want to say it was 2,000 patients that were enrolled. And these are people who had rheumatoid arthritis. They were enrolled from 98 to 2004, before biologics generally, or soon thereafter with the new criteria from 2005, 2010, 266 patients. And then the last decade or so, 2010 to 2022, 329. That looks like about 1,000 patients overall that were analyzed. And what they've seen is, while they looked at those cohorts at baseline, the vast majority of things were not different. Demographics were not different, tender joint count, swollen joint count, shared epitope, etc., right? But there were things that did differ and did change over time. Over time, since 2005, RA has become less seropositive. It's become less inflammatory as measured by CRP. It's become less erosive at baseline as measured by X-rays in these many patients. But it's also, at the same time, those are good things that say, oh, maybe milder, I don't know, maybe worse. It's hard to say, but seronegative with inflammation and erosions, I've talked before about seronegative patients aren't necessarily milder. They often are, in fact, worse. But they've also had more comorbidity, more smoking, and more steroid use. On the whole, you could say that, one, RA is changing. Is it becoming milder? I don't know. I think it may be becoming worse with more comorbidity, more inflammation, more erosions. But they're not getting more DMARDs, right? And their TJCs, SJCs are not worse. Another piece that goes along with it, this comes from the Mayo Clinic, and Dr. Mayasadova there and her friends, they looked at flare rates in RA, showing that over time, flare rates have gone down in RA. And I think it might relate to this trend in more seronegatives. Flare rates are higher with seropositive patients compared to seronegatives. With more seronegativity, lower flare rates. You can look at that paper. The citation is online. You can see that, and by the way, I'll be talking about flare rates at Room Now Live tomorrow and this weekend in Dallas. It's not too late to register, roomnow.live, if you want to attend virtually or show up and participate in the great fun that we're going to have. You can check out these citations and more on the website. Have a good week.